Good afternoon, everybody. Actually, I'm thankful to IIP Latur for giving me opportunity to moderate this session on infectious disease. Actually, I happened to meet my PG guide, Dr. Sandhya Kharse, madam. Please, she's not in the hall, but she will be very happy to see me after 15, 16 years. Again, my mentor, Dr. L.S. Deshmukh, sir, who had taught me how to practice pediatrics. So let us move on to the topic on infectious disease. This is what I learned when I started working in YK unit in my first post at JJ. What sir used to say, common infections, the irrationality works often, but rationality never fails. So let us try to find out some rationality in our discussion with day-to-day infections. So case 1 goes to Dr. Amol Pawar. This is a 10-year-old male child presented with high-grade fever of 5 days duration. Fever was low-grade to start with on day 1 and increased gradually over next 4 days. There is poor oral intake, lethargy, no history of associated cold and cough. On examination, child appears dehydrated, having sick look, vital stable. Systemic examination-wise, liver is 2 centimeter tender with a span of 7 centimeter. No palpable spleen. Other systems are normal. So what is the likely differential on history?
As this is a 10-year-old male child and fever was low grade to start with, so it may be bacterial, as in viral cases the fever usually is high grade, and also child appears sick looking and dehydrated, lethargic. So mostly this is bacterial, because in viral cases, viral fever, the patients are usually comfortable during the febrile period, and it might be urinary tract infection also, as this is 5 days fever. Then we cannot rule out this collagen vascular diseases also. In some cases of viral infection like dengue, patient may present like this. So it's a mixed picture right now.
Okay, very true. Actually, if I had to analyze it, I'll consider it's a 10-year-old child who appears to have a bacteremic bacterial infection which has not been localized. So by and large, during first week, day 5, no localization, 10-year-old child. So it appears like an enteric fever. That is one of the first differential. Because by that time on day 5 in 10-year-old child, most of the infection get localized. So this is for you, Snehal. On investigation, CBC suggests HB 10 grams, total counts of 5,400, polymer of 16, no eosinophil, platelet count 1.5 lakh, RMT NS1 is negative, Vidal test is positive by slide method in 1:160 titers. Can you comment on blood report and what is missing?
Sir, this baby is having hemoglobin of 10, is mild pallor. Total leukocyte count is 5,400, suggestive of leukocytopenia. There is no eosinophils. This is more important because we are now, this is a systemic disorder, bacterial disease, and now we are going towards enteric fever, because eosinophil count is 0 in 80 to 90% of the patients with enteric fever. Platelet count 1.5 lakhs, it is at lower normal limit. RMT and NS1, it is negative. And Vidal is positive in 1 in 60, both in O and H antigen by slide method. This is day 5 of fever. And Vidal is positive both in both O and H antigen. It is unlikely because O is positive by 6 to 8 days and H is positive by 8 to 10 days. Okay, so it may be anamnestic reaction. And what is missing? So missing is blood culture and typhoid. So we should do at before day 5, at day 5, if you are suspecting a bacterial disease, so we should go for RM typhoid. It will come positive by 3 to 5 days.
Okay.
And
I'll
blood
not go in
culture,
the depth
blood
of
culture
that.
must be sent before starting antibiotics.
Okay. Uh, Fine, sir. Actually, I had expected that slide method to be shifted on tube method. Slide method is not very ideal. You get report in probably 30 minutes or so. Tube is probably standard to consider. Probably turnaround time is around 4 hours. So slide method is something which is wrong. And what a typhoid out, I don't know about the validation of that. Any serology needs to be validated, like what we consider enteric typhoid Vidal test in initial days, and then probably after 2 weeks you see the titers. Those are not very rational. So by and large, you have to go for the gold standard blood culture. So why we are bothered about blood culture? So first thing, all district places in Marathwada are having facility for blood culture, and yield for the positivity is maximum in first week. So I think everybody should send blood culture in first week of fever, and take into consideration blood broth ratio of 1:4 to 1:5. So why we are considering blood culture? You have few reports in last 2 years how salmonella is behaving in our area. So first one is the most common report which we get. So this is a dream report when you have sensitivity to ampicillin first generation, Septran also, then our favorite ceftriaxone. So this is the ideal report we get in 50 to 60% patient. But the same thing, many a times you have higher MIC for ceftriaxone, means you will get more time for defervescence. Then you have again nightmares with salmonella, that you had ESBL positive salmonella not responding to even beta-lactamase inhibitors, as well as even they are sensitive to carbapenem. So this condition has come up. Even sensitivity to first generation chloromycetin has come up, but you know that this is not an ideal drug and it has its own complication to be given for 14 days. Then again we have the other report which is showing fourth generation cephalosporin, beta-lactamase inhibitors and carbapenem to be sensitive. So we are going towards that era. That's why I did put this slide. So next question to Dr. Amit Toshniwal. This child was started on IV ceftriaxone. Once we had a positive Vidal and we did send the blood culture. On day 3 of fever, the child is still running fever. What is next possibility?
Normally, clinically, this one diagnosed as enteric fever and blood culture positive. How is the rest of clinical condition? Because initially he was sick looking, dehydrated. Is he improved clinically that way?
So very true. Actually, defervescence in enteric takes 5 to 7 days even we start ceftriaxone. So on day 3, even if the general look of the patient is improved, we can wait for another 2-3 days. So general look is the first thing which improves, then fever goes down. Don't be in hurry to call it an resistant variety or a treatment failure. So next question for Dr. Ashwin Kathar, sir. This child improved on 5th day of illness, fever decreased, then defervescence acute. Antibiotics were given for 14 days. After 3 weeks, came back with a febrile illness of 4 days duration with no localization. What are the possibilities?
As this patient has already adequately treated initially for 14 days, but he still had another fever spikes after 3 weeks. So considering the previous history, we should consider this could be a relapse of enteric fever. But it is only confirmed if we rule out other causes of fever. Once we ruled out other causes of fever, we can think for it's a relapse enteric fever.
Very true, sir. So relapse we can treat with the same medicine which we had used for the first episode.
We should treat with the same medicine.
And there is one catch in that. If you have an allylixic acid sensitivity present on your blood culture on first report, prefer that as the drug of choice for relapse. So going back to Asad, our key message is in view of growing ESBL salmonella, emphasis should be on establishing microbiological diagnosis by sending blood culture. As I and many of the people sitting out here are thoroughly irrational, they write azithromycin left and right. So I just want to spare that precious medicine. So just give your opinion about preserving azithromycin for salmonella or enteric fever.
Actually, recent studies have come that even in typhoid fever, we are getting multi-drug resistance, extremely drug resistant cases. in which we are getting resistance to first line and second line antibiotics that we traditionally used. But azithromycin is the drug which has been shown to have action, a good action against all these multi-drug resistant and extremely drug resistant cases. So as sir said, if we continue to use azithromycin right and left, there are chances that even the resistance will develop to this drug and then we will be in a big trouble. So it is advisable to use only if it is needed, and we should not use it as a first line drug as it is shown even in outpatient or inpatient cases. It should be a second line drug only if you establish that your first line drugs are not acting. That is why my view.
Very true. The biggest advantage with azithromycin is that it has an intracellular penetration. We know Salmonella is more of an intracellular organism. So when your first line drugs doesn't work, it is the best option to be used in IPD and OPD both cases. So this is the second case, Dr. Snehal Nagre. This is a 5-month-old baby with low-grade fever, running nose, cold for 2 days. Developed feeding difficulty with breathing difficulty since morning. On examination, it's a well-grown baby. Tachypnea of our respiratory rate of 60 per minute with subcostal and intercostal retractions. No adventitious sounds on auscultation. SpO2 90% on room air. What is the likely diagnosis?
Sir, this is 5 months old baby with low grade fever to start. Running nose is there, cold for 2 days. And now he have feeding difficulty with breathing difficulty since morning only. So this is likely a viral disorder to start with, upper respiratory infection. And now since morning he is having breathing difficulty. This is a well-grown baby. Tachypnea of respiratory rate of 60, which is more for his age. And saturation is 90% on room air. So the likely diagnosis, this is acute bronchiolitis.
In hypoxia.
With hypoxia.
Okay. So going back to Amol, can you just give a short comment on management of this child?
So as the respiratory rate is more than 60, so and work of breathing is also increased. So we have to admit this patient, we have to hospitalize this patient. Okay. We have to give proper hydration. Then we have to manage the symptoms. There may be some nasal obstruction also. We have to use decongestant. We have to give proper IV fluids. Then we have to start with oxygen. And we may have to start nebulization with hypertonic saline.
Okay, main thing is to give a supportive treatment. So what is required is to take care of hypoxia and hydration. Hydration, you will give IV fluid. For hypoxia, depending on whatever at your disposal, whether you have a high flow or low flow oxygen devices, depending on the condition of the child, you can start. Role of chest X-ray. Dr. Toshniwal?
Mostly it is as bronchiolitis, so as such that X-ray is not going to help much because there is more of a air trapping or hyperinflated lungs. If you are suspecting very high grade fever or if not responding that hypoxia, then you can go ahead with X-ray to look for any aspiration. Otherwise for bronchiolitis, usually X-ray not required.
You are telling that honestly? You had admitted that child. You are honest enough not to take X-ray of a child with respiratory distress who is 5 months old?
Not very usual.
Okay, so it's a clinical diagnosis for you.
Yeah,
so when you will advise X-ray in this child?
So this continuous high-grade fever might be there, or if hypoxia is not improving, then only we'll go for this one.
So whenever you are suspecting a complication or no improvement, otherwise in a straightforward case when you had admitted the child, we tend to look for some multifocal patches on X-rays and we are happy that we can start him on antibiotics. That's the bread and butter. So any specific investigation to isolate this viral illness, and go back to Asad. He's supposed to tell me about biofires. Had you sent that any time? First question.
Yes, sir.
Had you sent biofires any time?
No, sir. No, sir.
Why?
So because theoretically speaking, the multiplex PCR appears to be a very good test that it will investigate the viruses and the bacteria at same setting. and with this we can have differentiation of viral and bacterial, and a bacterial diagnosis, if it is not there, it will avoid unnecessary use of antibiotic. Plus it will give you specific virus also to use specific antivirals. But if we see the cost of this test, which is 5,000 plus, and the cases in which
12,000 to 15,000.
Yes, sir.
12,000 to 15,000.
Okay, for respiratory panel.
It's a big panel.
So what case we have been described, almost we see at least 5 to 10% of our OPD is full of such cases. Almost I'll say 30 to 40% of our admissions are like that. So for such chunk at place like this, if we are sending 12,000 to 15,000 case, I'm not sure that is justified. Second thing is, it again fails to differentiate between colonization and actual infection.
Excellent.
So its cost effectiveness, I'll definitely question. I'll say we should not use it routinely, but if you are suspecting severe immunocompromised status where you really need to differentiate between individual viruses and bacteria and go ahead with specific antimicrobials, then in that case I think we can go ahead with this test.
Okay, to summarize it, it's an excellent test. Cost is the major issue. Another thing is that we don't know whether it's a colonization or that's a really organism which is causing the disease. I'll go back to Dr. Ashwin Kathar. Tell me honestly, what is the role of bronchodilator? You must be seeing around 10-15 cases of bronchiolitis per day now, this present epidemic, and how frequently you are giving bronchodilators?
Ideally,
Tell me honestly.
Ideally, there is no role of bronchodilator, but still we are prescribing. Because the pathology in this case is not the smooth muscle involvement. It is the excessive mucus production and the mucosal edema that is causing the blockage of that airway lumens.
And which bronchodilator you use?
No.
Don't use?
No.
No, never use selective or unselective like adrenaline or anaesthetic nebulization?
Hypertonic saline, 3% saline, or adrenaline nebulization we can give.
There is no
it
role.
has little effect as compared to bronchodilators.
Okay, bronchodilators don't have any role as per Dr. Ashwin Kathar. I'll go back to Asad. I am very much interested in giving IV F-Corlin and budesonide nebulization. That's probably bread and butter for me. So what is your thought process on that, along with hypertonic saline?
This is a very, as we'll hear a lot of controversial questions in our conferences. This is one of them. So for this, sir, first of all, I would like to quote a sentence in Nelson, which clearly says that steroids, whether they are inhalational, intravenous or oral, they have shown conflicting, sometimes even negative studies in case of bronchiolitis. So that's why we should not use it if we are very sure about bronchiolitis. But bronchiolitis, as sometimes the closest differentials are also early Wheezer maybe, and if there is absence of fever, family history is there, then with
First
episode, sir, we should not use. For first episode, first visit, we should not use. If the presentation is with fever and the typical presentation this child had, in that case, we should not use.
Hypertonic saline?
Hypertonic saline, yes, we can use hypertonic saline because there has been a meta-analysis done. Almost there were 7 different cohort studies which combined together. The total sample was almost 591 infants. There it showed that if we use 3% normal saline, there are 2 advantages. One, the length of stay in the hospital, it decreases. And second, the clinical severity score in both outpatient and inpatient, it had a significant improvement with 3% normal saline. So I think there is no problem in going ahead with 3% normal saline, but its acute use, like 1 or 2 nebulizations, how much difference they can make in a case of bronchiolitis, that needs to be studied more because there is no sufficient evidence for that.
So you don't want me to give a nebulization with steroid, bronchodilator, and you don't want me to write a prescription of antibiotics. So what I'm supposed to write on paper? IPD chart.
IPD, sir, I think in this case we are supposed to write down oxygen, IV fluids.
Oxygen is the drug. What order you will be giving?
Oxygen?
Oxygen is a drug. I probably taught you 3 years back.
Sir, oxygen is the drug in bronchiolitis.
Oh.
It is the only drug, I think, which has been shown to have.
That has to be order for that. How much liter, how much time?
Yes, sir.
There has to be order for that. 4 liters per minute by which device you are giving, that has to be written.
Yes, sir.
And along with that IV fluid,
Yes,
there are
sir.
many things like if
And
the child-
antibiotic on a SOS basis for fever, I think that should be enough for bronchiolitis.
Okay. So moving to the next case, this is a 2-year-old child with cold, low-grade fever and cough. Developed respiratory difficulty since morning. On examination, the child is irritable. There is tachypnea, there is subcostal intercostal retraction. On examination, bilateral scattered crepes and few bronchi. Likely diagnosis. Going to Dr. Amit Toshniwal.
It looks like community acquired pneumonia.
Okay, you think it's a community acquired pneumonia. Better you don't, you haven't told lower respiratory tract infection. So I'll go back to Asad. How to differentiate viral and bacterial pneumonia?
So first of all, if we have to start clinically, then virus and bacterial pneumonias, just like any viral or bacterial illnesses, viral, they will have maximum onset of fever, severity of symptoms will be quite high in the beginning. Bacterial, they will gradually build up. Second, duration of the illness, usually 7 days. If the duration is more than 7 days, it goes more in favor of bacterial, though coronavirus has, put a question mark on that, but still traditionally more than 7 days goes in favor of bacterial. Then other associated symptoms, like if other systems are involved, diarrhea is there, rash is there, that will go more in favor of viral. Presence of suppurative otitis media will go more in favor of bacterial. Unilaterality and bilaterality, this is one more important indicator. Usually viral pneumonias are bilateral and bacterial are unilateral. So that will be for clinical. As per the x-rays are there, the first x-ray, it is showing significant.
No, I haven't gone to X-ray. This is the same patient's X-ray. Apart from a clinical history, what you told, okay, you have history of multiple peoples in family which are ill.
Yes.
Along with that, you have a low-grade fever and subsequently developing respiratory distress in viral compared to bacterial, which is acute onset high-grade fever, which chills, not much of the cough, but those are having more picture like sepsis. So an acute presentation. So can you tell me whether any investigation like blood investigation which helps us to find out if it is bacterial or viral pneumonia?
Prolactin levels.
Okay, can you elaborate procalcitonin?
Procalcitonin levels.
Okay, for the kind information, neither CBC nor CRP help. It is raised in both viral and bacterial. It is for the sake of our heart that we consider our mildly raised CRP to be bacterial. They have no role actually. How frequently you see a CRP of 80s or 110 to consider it's bacterial? That is all adult data, and we just keep on a positive CRP counts वाढलेले आहे bacterial आहे तसं काहीच नसते. But they are just a defense mechanism. Anybody can, even a viral or bacterial infection can give you a high count. So they doesn't differentiate bacterial or viral. Procalcitonin in adult studies has been found to be significant enough to consider viral or bacterial pneumonia, but they have their own cutoff values. When we try it, 0.5 level in a Bachu patient with pneumonia, we never come to 0.5 level and we can't say it's bacterial. We need more data, more studies on procalcitonin, but that looks promising. So going to the X-ray number 1.
X-ray number 1, sir, there is significant radiolucency looking like air trapping with slight prominence of bronchovascular markings. Such type of picture we get usually more in viral pneumonias.
Okay. Case number B is a 2-year-old child with high-grade fever, cough and increased respiratory activity of 2 days duration.
It's a 2-year-old child.
Yeah.
So there is a radiopacity on the right side, right upper lobe radiopacity is there. Within that radiopacity, peripheral area is more radiopaque. So it is more like a consolidation and collapse.
So it appears like a lobar pneumonia.
Yes, sir.
Case number 3 is a child who is going to the school, is having cold cough and low-grade fever of 4 days. And we found clinically the child is having bilateral bronchi, but his X-ray is something which is unusual. There is clinical radiological dissociation.
Sir, this is a school-going child, asthmatic child. Looking at the X-ray, there is involvement of either lower part of upper lobe on right side or upper part of middle lobe on the right side, or maybe both. We cannot comment. It could be multilobar involvement. Plus, there is hilar prominence is there. So this looks more like a atypical organism associated with this. As you are saying, there is radioclinical dissociation is there. So I'll say this is more of a atypical pneumonia rather than a lobar pneumonia.
Fine. Case number 4, X-ray D, is a child 2-year-old who had come with cough and cold, increased respiratory activity and high-grade fever of almost 7 days duration.
Sir, this X-ray is showing obliteration of right costophrenic angle. There is a uniform radiopacity is there. So pleural effusion is there, but there is no significant push to the trachea. Rather, it is slightly pulled towards it. So there must be underlying consolidation and collapse. So this is like a syn pneumonic effusion.
So fine, can you find out the organism with that? Can you comment on organism which is causing that? This is a common X-ray which we see.
The last one which we saw of syn pneumonic effusion, usually most common organisms being Streptococcus pneumoniae, Haemophilus influenza and Staphylococcus. But Staphylococcus, sometimes they tend to have bullous picture on the X-ray. So I will go with Streptococcus pneumoniae for that X-ray.
Okay, fine. So there are few WHO definitions of pneumonia, no pneumonia and severe pneumonia. No pneumonia, when you just have cough and cold. What they defined pneumonia as per WHO guidelines is concerned because you have to treat to the whole community. So it's just a fast breathing associated with retractions. So when you consider it to be pneumonia, saturations more than 92%, severe pneumonia, the saturations will be less than 90% associated with fast breathing and retractions. So these are the guidelines for respiratory distress in children. As we know, tachypnea, retractions, increased work of breathing, grunting, nasal flaring, apnea, altered sensorium and saturations less than 90% on room air. So this is for therapy for pneumonia. As we know, neonates more of gram-negative infection or chlamydia. So likely medicine which we can use is 3rd generation cephalosporin along with gentamicin or amikacin, or we can add on erythromycin or macrolides depending on how is the response. Less than 5 years, commonest organism pneumococcus, H influenza and viruses. Drug of choice is still amoxicillin, co-amoxicillin, ceftriaxone or ceftriaxone for inpatient. More than 5 years, again it's streptococcus pneumonia with or without mycoplasma. Amoxicillin is the drug of choice. If the child doesn't respond, shift on to macrolide. If the child is very sick, you can add both. Then you have MRSA in suspicion. That time you can add on vancomycin, linezolide or ticoplanin. If you are suspecting a gram-negative infection in an immunocompromised child or somebody is in ICU for a long time, then beta-lactam. Beta-lactam is inhibitors with aminoglycoside, or you can go for fluoroquinolones. And when you are suspecting influenza, that is the only antiviral you can use, Tamiflu. So conclusion, pneumonia is the leading cause of mortality and common cause of morbidity in children below 5 years. In developing countries, what we had been taught, viral pneumonia is more common, but that's a waste literature. We have more of bacterial infection, and Streptococcus pneumonia is the most common organism. And this is the catch. Administration of appropriate antibiotics in early course of pneumonia alters the outcome of illness. We cannot take help of this line to rationalize ourselves. We need to analyze whether it's bacterial or viral, and then we can decide on antibiotics. Oral amoxicillin is the drug of choice. For outpatient and inpatient, co-amoxicillin is the drug of choice. Case number 4, to Asad again. 6-month-old male child having cough, cold, fever for 4 weeks now, had repeated consultations, had been hospitalized with working diagnosis of LRTI. Fever used to decrease, but cough, cold continued. Loss of weight of 1 kg over 1 month. On examination, BCG mark is present. There are few scattered crepes and bilaterally.
Sir, clinically, as the cuff is 4 weeks now, with there is loss of weight and child is hospitalized with working diagnosis of LRTI, must have been treated for LRTI and still not improving. With the X-ray showing right costophrenic obliteration and there is pleural effusion on right side and hilar provenance, I would like to keep my differential diagnosis as pulmonary tuberculosis.
This is primary complex, you want to tell me?
Yes, sir.
This is primary complex.
Though the Gone's focus is not very...
How many times you had seen primary complex?
Very rarely, sir. So it is not primary.
So you can consider it's suggestive for tuberculosis rather
Yes,
than...
sir. Suggestive of tuberculosis, yes.
Okay, Dr. Nagre, I did put a Mantux on this child with 5 TU, whatever is available with me, and Mantux is 10 millimeter for a 6-month-old child. And I did send gastric lavage fluid early morning, and strangely I got a MTB detected, which is RIF sensitive. Your comment on that?
Sir, as we are suspecting a patient of tuberculosis, because there are 3 cardinal features present: persistent non-remitting cough, fever more than 2 weeks, and weight loss. So we have done. We should go for now investigate this patient, and tuberculin test done here. It is 10 millimeter, but it should not be done because tuberculin test only shows that there is infection. It may be positive with BCG. Again, it will not differentiate between disease and infection. So we must go for microbiological confirmation, and and gastric lavage must be sent.
So it is sent and it is positive with gene expert. What is your comment on that? What is the advantage of that?
There is MTB is detected and it is rifampicin sensitive, so it will help in guiding the treatment regime also.
Okay, we have a CBNet or gene expert available. There are 2 advantages of that. At the outset only, we get rifampicin sensitivity. You go for a universal drug sensitivity by this. Yield is more compared to what we used to do, ZN staining by smear. Yield is more, almost 30 to 40%, depending on which case you had selected. This case fits in diagnosis of tuberculosis, so there is high chances of isolating it.
Yes.
Okay, and as far as Mantux is concerned, Mantux is for detecting latent TB. It is not for active TB. So there is no point in doing that. Many of the times we do Mantux and then start EKT on the kids. So most important thing is microbiological isolation. So we have an X-ray. Amol will guide us. I found the mother of the child coughing. वो बोला कि थोड़ा सर्दी खांसी है, 1-2 महीना से है, और वो बताया था तो एलर्जी है बोला डॉक्टर ने.
So this is the X-ray
Always
of
look
mother.
for contact.
Okay. So we have to take again proper detailed history of contact, whether there is any family member having this such symptoms of cough and other things. And looking at this X-ray of mother, I think you told.
Yeah.
So there is a effusion, pleural effusion on right side of the.
So we asked her to, she doesn't have much of the cough. We induced the cough with normal saline and we found her sputum to be negative for CB0. Now what? Still TB or not TB? Oh, that's not a criteria. You can try honestly to isolate organism. If you haven't got that,
you have to look for organism in fluid.
So if I did aspirated the material seen for cytology, microscopy and CBNet, so tell me what is the yield of CBNet for pleural fluid and probably an ascitic fluid in some cases. So yield is less. So by and large, yield of CBNet is less for pleural and ascitic fluid. It is best for GL, ball, sputum, even a tissue, whatever lymph node we take. So we'll go on drug therapy with Dr. Toshniwal. So first thing I report that this child, as per RNTCP guidelines, on Nagre app and did serology of both parents, which is negative. So that is most important work you are supposed to do. Now start drug therapy to the child. Dr. Amit Toshniwal.
So this one, we have to start this categorically new case like this is bacteriologically proven, this one, tuberculosis. So 2 HRZD and 4 HRE, it will be the regime for this child.
Why you need 4 drugs now? Previously we were happy with Mecox ZH kit, our pet medication with positive Montox in our OPD. Now ये तो सब भानगड़ हो गया, वहाँ सिविल में भी बोलना है, GL जमा करना है और 4 ड्रग इस्तेमाल करना है. What is the fund of giving 4 drugs?
There is community, this one, rifampicin, this one.
Okay. We want to go for large kill in initial first 2 months, so we need 4 drugs. As we are living in India, where mono-resistant to INH is 4%. So as per WHO, it's a high endemic area for INH mono-resistance. So we need to give 3 drugs in continuation phase. So we continue with ethambutol along with INH and rifampicin. As far as the second regime is concerned, that is retreatment. You consider that to be a holding regime. So when you have a patient who has gone for relapse, or the patient who has got treatment failure not responding, or the patient who is defaulter, so we actually try to go for microbiological diagnosis by any method. You have to take sputum, you have to send that for smear, you have to send that for liquid culture, you have to send that for line probe assays. Liquid cultures, MGIT, are sensitive. Just take 2 weeks for growth of organism. Compared to what we used to give LJ media, which takes 6 weeks for organism to grow, and sensitivity within 2 weeks. So it's a 4 weeks regime. You have to wait for holding regime. You have to wait for 4 weeks. Line probe assays, that is again a good amplification PCR technology, where you can get an yield of organism within 2-3 days. So once you got a sensitivity of all the drugs, first and second line, you can make a regime. And finally, we just have 2 regimes. One is for drug sensitive TB and other is for drug resistant TB. So there is no category and category 2. Even if after doing microbiology and sensitivity, we found the patient is sensitive to first line drug only, we can safely go for a drug sensitive TB regime, that is category 1. So again, this is recent update as per RNTCP. As per the newer pharmacokinetics, the dosage has been revised. Now we have INH by 10, rifampicin by 15, then ethambutol by 20, pyrazinamide 35, streptomycin 20. And don't consider those drugs to be of inferior quality or generic, because they are prepared by macloids. They are better drug than what we used to give in our OPD. So we have a fixed drug combinations which is dispersible, INH, rifampicin and pyrazinamide for initial 2 months, which is in dispersible combination of 1:5 and 2. And ethambutol, as it is hygroscopic agent, we don't have a dispersible tablet for that. Going back to Dr. Ashwin Kathar, sir, tell me the role of steroids in tuberculosis.
As we know, TB is associated with significant host response, which will cause tissue inflammation and fibrous proliferation. And if this happens, it will lead to poor clinical outcome due to tissue damage. So to reduce this tissue host response, we should start with the steroids.
Okay,
and
sir.
it is mainly indicated in case of TB meningitis, TB peritonitis, related to pleural effusion, endobronchial tuberculosis. So these are the few indications.
Okay. Amol, please tell me the role of pyridoxine.
Sir, to prevent the INH-induced peripheral neuropathy, we have to use pyridoxine. And in recent NTP guidelines, they have mentioned that you have to give to all children. If drug-sensitive TB is there, then we have to give 10 milligram OD dose. And in case of drug-resistant TB, we have to give 50 milligram OD.
So this is a misprescription. We have to follow the guidelines. We can give pyridoxine to all children because they are considered malnourished. 10 milligram in drug sensitive and 50 milligram in drug resistant TB. Pyridoxine became essential because the dose of INH has been augmented now. We are giving by 10 milligram per kg. Asad, how will monitor this patient during follow-up?
See, the moment we use the term monitoring, time has to be there. So the question we need to answer is when and what to monitor. So when it comes to clinical, so your clinical visits can be weekly, but the most important visits are at the 4 weeks and 8 weeks of interval. What are you going to monitor in this is the fever, whether it is increasing, decreasing, cough, weight, then the appetite of the child, generalized well-being of the child, which is a subjective thing, but yes, we have to consider that. And obviously the lymph nodes, if they were there, you were able to palpate, then what has happened to its size. So these are when and what in case of clinical. In case of radiological, if the child is having improvement, then we don't have to do a radiological analysis. We can do it at the end of the therapy. What we see is we are having a baseline X-ray. We see what is happening to its shadows. And if we are seeing clinical deterioration, then you have to do a X-ray at the end of your initial phase. Regarding microbiological,
what is the role of that X-ray after finishing of the therapy?
If it is showing worsening or there hasn't been any resolution with clinical deterioration, we are supposed to continue the intensive phase for 4 weeks another.
Oh, there is no question of repeating at 2 months after initial phase. After finishing of the therapy, you are supposed to document an X-ray, and what is the utility of that X-ray?
Utility of that X-ray when we are doing, if the child is improving clinically, and at the end of it if we are doing, then it might show the improvement, but apart from that, there is no significant utility of the X-ray in a clinically improving child. If
the child is having lymph node, that will persist for next 2 years. That doesn't decide your duration of therapy. So there is no utility apart from that. That child has been treated by me, and if he goes to you after 6 months and you say there is again lymph node in the this one mediastinum, you need an AKT again, now you are relapsed. So there is no utility of X-ray. You can just take it for documentation.
Yes.
Next time when he consult to a doctor for similar complaint, they should see that that lymph node is there persistent. Microbiological?
Microbiological RNTCP says that you have to do a microbiological monitoring at the end of intensive phase in every patient. The role of that is to, role of every this thing monitoring, the question why we are monitoring is that we have to pick up the failure cases early. That is the main reason. And the moment we are picking up failure cases, we have to do all that is in our limits to extract the microorganism and do a sensitivity testing, because that is going to be life-saving for the patient. So that is the purpose of this whole monitoring response.
So at 2 months and after continuation phase is ended, you are supposed to go microbiological.
Yes.
Coming back to Amol, these are 2 adolescent female child.
Excuse me, sir, time is up.
Yeah, I will take one case only. 2 adolescent female child who has come to me with pyrexia of more than 2 weeks. There is no associated cold and cough. As a part of PO workup, we did an X-ray which is showing mediastinal widening and heterogeneous opacity bilaterally. Along with that, we have a positive Mantoux which is 20 millimeter, ESR more than 60 millimeter, and we try to get an induced sputum which is negative for AFB. So what is your comment on these X-rays? How we are supposed to proceed further?
First X-ray is showing hilar lymphadenitis, and there is a patch on lower lobe right side.
Sir, I'll cut short. I just want to start AKT on this child. Mantoux is positive, mediastinal widening is there. There are bilateral heterogeneous opacities, both kids. I want to start AKT because they are adolescent female. I have too many things
So I have
with
to
me.
confirm the diagnosis first with
So need a microbiological confirmation. How will you do that?
bronchoalveolar.
We did a sputum, induced sputum which is negative. I think that is well enough. Excellent. So we need a biopsy. First look for any traceable lymph node in cervical area. If they are available, you can go for biopsy, or you are supposed to go for a CT chest for CT guided biopsy. Case 1, we did a CT guided biopsy, and It terminally turns out to be a non-Hodgkin's lymphoma. Case 2, I should thankful to the radiologist at my disposal. He did a interscapular area puncture and then got some material from the paratracheal lymph node, and we got a CBNet RIF sensitive. So that was tuberculosis. So we need to confirm diagnosis. We cannot start AKT empirically. To try to establish a bacteriological diagnosis as far as possible. And the aim of anti-tuberculous treatment is to cure the patient in short period of time, to prevent death and late effect of disease, prevent relapse, and prevent drug resistance. Diagnosis and treatment of MDR TB is highly specialized and should be in consultation with expert. Can we take one case?
No, sir. No, sir.
Thank you.
Thank you, Izhar, Jaweed, sir, for highlighting minute details of routine cases which we daily see in our practice.